Thanks to Dr. Devan Sood for this kind invitation to participate here. I think all of us are familiar with glaucoma diagnosis, risk, and field testing. But what we should know, what we should sort of fine tune and hone your skills to pick up the field that is glaucomatous and not to miss the glaucomatous field, not to diagnose. I generally suggest as a checklist before you start interpreting a visual field is to make sure you're reading the correct chart. And if you're in a busy institute, you probably have charts of some other patient institute inserted in the patient's chart. So make sure you're reading the correct patient's chart. Make sure that the field test has been done reliably. Make sure the pupil size of the patient is at least about 3.5 before you even do the test. And make sure the pupil size remains about the same and the test is being done. Also make sure that the refractive error of the patient is kept into consideration. The visual field is being done. The type of perimeter can decide whether you're doing near correction or not. And of course make sure that you're not interpreting and treating based on the first visual field the patient has ever done in his life. So there is a learning curve. Make sure you have at least 1 or 2 fields before you come to a baseline, and then have a baseline, and then you start looking at progression and so on. And once you have an abnormal test, decide whether it is statistically abnormal, and then of course once it is in a really an abnormal field, you have to correlate clinically and then decide is it glaucoma or not. All abnormal fields are not glaucoma, so make sure it correlates clinically with what we know as glaucoma. A systematic interpretation would definitely help. Obviously I can't go through a systematic interpretation now. Of course you need to look at what I said, the patient data, the patient's age and other ID, and make sure the test is reliable, adequate fixation, no fixation losses, and false positives, false negatives, and so on. This is the Humphrey printout. The octopus has something similar. In this you have similar things like the false positives, false negatives, and also you have patient data, and all the other data has to be first checked before you start interpretation. The most important part of the visual field will actually be the pattern deviation, the corrected probability of the octopus. This is similar in the Humphrey as well, the pattern deviation. And also in this you look at the corrected probability, and of course you can look at the defect curve and tell you whether this is abnormal or not. In the direct projection machines such as the octopus, you don't need near correction, but in the Humphrey machine you need near correction for doing the perimetry. And for high myopes and for FX and so on, generally prefer to use a contact lens for doing the visual field itself. And of course make sure your technician has placed the trial lens properly, placed the patient properly with the chin and the forehead touching the machine correctly. And also make sure the trial lens is centered properly so you avoid all the artifacts related to the testing. And of course, as I already mentioned, the pupil size is extremely important. Don't do it on patients who are using pilocarpine and with the 1 mm pupil and so on. You will not going to get good feeds, so make sure it is dilated before you do. And if you are dilating, some of the instruments can give you an automated pupil measurement. So make sure the test is done at the same pupil size every time. And of course, you also need to know that whenever any of us does the field test for the first time, you don't do it so well, and you will probably have fixation losses like this. This patient did the test first and then subsequently realized that it didn't do it so well. The test was repeated, and you find a few days later you're getting a much more better looking or near normal field in the same patient. And similarly, inattention is a very important thing for most patients. False positives, false negatives, and fixation loss. The patient should be instructed properly and as to what is expected of him in perimetry, and the instruction has to be told by the technician in a gentle, slow manner. You can even do a demo test for the patient and then subsequently subject the test to one eye, give a little rest and do the other eye a little later. There is no need to rush a patient through perimetry, because what you will get out of 15 minutes may be something completely of no value at all to the patient and to yourself. This is a patient who sat through the entire test. When the patient was told to sit in the machine, look at the search for this stimuli coming on, patient did just that without pressing the button. You will find that the entire thing was fully false negatives of 99%. Patient was not told to press the button. This patient has advanced glaucoma and has a lot of fixation false negatives. In advanced glaucoma, you must understand that false negatives are pretty common. So only false negatives alone don't make the test unreliable. So in a patient with advanced glaucoma and you have pressures of 40, you have 0.8 cupping, then you know that this field is definitely abnormal. You cannot dub this patient as being unreliable. And similarly, you have a patient like this who is about 91 years of age. I think it's probably not fair to subject very elderly patients and very young patients to perimetry and expect to get meaningful results. So is the field abnormal? Once you've done a field test, by statistical criteria, you want to decide, is the field test abnormal? You should, in the Humphrey printout, you have a cluster of 3 or more non-edge points on pattern deviation, and at least 1 point in the less than 1% significant level in the pattern deviation plot here. This field is very obviously abnormal. And you have a PSD or a CPSD of what occurs less than 5% of normals. And of course, the glaucoma hemifield test should be outside normal. This criteria is what we standard is what we follow worldwide. as called the Anderson's criteria for abnormality. And of course, there's a new index called the visual field index, which is now just below the GHT here. This is a new summary of the visual field status that's giving you a single percentage of the normal age adjusted visual field. Actually, it's a single score, like how much you score in a particular subject, like in maths, you score 80% or 90%. The higher the score, the better it is. 100% is obviously normal, but it's an oversimplification of the visual field giving a single score, but it is center weighted to correlate with ganglion cell density and visual function. It's a very nice way of telling the patient your visual field is about 98% normal or 95% normal and so on. And the more important thing for us as glaucoma people is that it's optimized for progression analysis nowadays. So you can use this particular aspect of the software to look for progression and so on, and it is less affected by cataract and media changes. The visual field index is also an important aspect of the evaluation. If you people who use the octopus, the MD more than 2 decibels and LV more than 6 decibels is abnormal, and similarly at least 7 points with sensitivity less than 5 and 3 of them being contiguous is again abnormal in the octopus visual fields. The defect curve is a very elegant way of looking at the visual field, and this is normal when the patient's test result lies within this confidence interval. This is generalized depression. This is localized scotoma. This is generalized depression with a localized scotoma. It's a very easy way of looking at the overall changes occurring in the visual field when using the octopus machine. And most of us would do the 30-2 or 24-2 as the first test. What is the difference? If you're going to have edge points, you can probably ignore them in the 30-2. But if you're going to do a 24-2 and you say edge points are not important, you look at this particular patient, we had a high suspicion that the patient had glaucoma. We did a 24-2 and looked at the GHT as borderline. There's some edge points being abnormal. We had a doubt and we went ahead and did the 30-2 as well. If you find the 30-2 is clearly showing an abnormal field. To make sure that in a suspected glaucoma, you should probably look at the fields, preferably 30-degree field. And sometimes, of course, we can also do the 24-degree field. And similarly, if you're doing fields for advanced glaucomas, 30-2 would show you field loss close to fixation. You will find that this data is not enough for us to manage this patient. So what you would like to do is you would like to do a central 10-2, and why is that? Because you're looking at 68 points with 2 degrees testing points between what is being tested. You're looking at a very close look at the central 10 degrees for the visual field. That's when I think you should need to understand that in advanced glaucomas you have to do a 10-2, even go ahead and do what is called a 5-degree field or the macular field and so on. Not every glaucoma patient would need this, but advanced glaucomas threatening the central 5 degrees, central 10 degrees, you need to do these kind of fields. Now, for some time you will find very advanced glaucomas, you will get a black field like this, no meaningful data at all. That's because you're using a size 3 stimulus. Actually, you can change parameters, use a size 5 stimulus sometimes. You will find that some useful data you will get out of the visual field if you change the stimulus size. This may not be useful for monitoring progression, but you have some idea of what the visual field is like. And similarly, sometimes I find the 24-2 and 30-2 is completely normal. That is because we are testing the testing grid 6 degrees apart in perimetry, in automatic perimetry using the Humphrey. And if you strongly suspect there's something going on in the visual field, you don't have a swap on a machine, you can actually do a 10-2 and you will find the field effect showing up on the 10-2 which is not showing up on the 24-2. And finally, is it glaucoma or not? You should follow the arcuate pattern. It should be asymmetrical across the horizontal. It should be 5 to 25 degrees from fixation, not attributed to other pathology, and clustered, and should correlate the appearance of the optic disc. And here are typical field effects of an RNFL defect and a corresponding field defect. Similarly, you have RNFL defects and corresponding field defect. This is very advanced glaucoma, so straightforward diagnosis. This again, I think Dr. Pradeep was telling you about correlating clinically. This is a patient who had a photocoagulation and this field effect is not entirely due to glaucoma. This is non-glaucomatous disc and corresponding field effect, again AON. Then of course if you have a field effect like this, very classic hemianoptic pattern, you're obviously not thinking of glaucoma. But if you have bilateral symmetrical field loss and you individually look at fields like this and you may suspect it is glaucoma, you put the fields side by side, and if you correlate and you look at the patient's symptoms, you should maybe not miss out a neurological problem if you have bilateral symmetrical field loss not looking exactly like hemianopia. These are things which you should not miss. And lastly, you must also remember that field defects occur much later in the disease. You can actually have disc hemorrhage, you can have an RNFL defect, and finally only then you may have subsequently in the end stages after 40% or more of ganglion cells are lost. That's when you start seeing field defects. So obviously structural changes are going to occur earlier than functional changes. So don't exclude a patient as having glaucoma based only on perimetry. So what you should again remember is that structural tests like disc and non-fibril analyzers will pick up early glaucoma. Functional tests like blue and yellow perimetry and flicker may do that also. But if you're going to have a test for screening, diagnosis and follow-up of patients, Use white on white perimetry, the full threshold, theta, theta fast, and of course in the top, and the dynamic for the octopus users. Structural tests are very little used if you are having end-stage glaucoma. Perimetric tests are useful, of course, but you should use low vision strategies and consider kinetic perimetry when you have advanced glaucomas. Thank you very much.